Okay, hello everyone, and welcome to our second day in the third Patient Safety Conference. My name is Lamia Al Hazzani. I will be the moderator for this track, the patient and family role in improving diagnostic safety. So, we would like to begin our track with a story shared by a mother of two type 1 diabetic patients, and let's listen to Maryam Asad's story. Hello and welcome, Maryam. I would like you to start by introducing yourself and then telling your story and sharing your story with our audience.
Thank you. It's a pleasure to be here and to be a part of this conference. I am Mariam, and I am a mother of two children with type 1 diabetes. I have a third child who does not have the condition. And my daughter was diagnosed 6 years ago at the age of 9 years of age. She's now 16. And my son was diagnosed 3 years ago at the age of 17, and he's now 20. The diagnosis of my daughter came as a huge shock to me. I wasn't expecting it. She was ill the day before. She had eaten jelly beans and had an allergic reaction, and her eyes puffed up, and she couldn't swallow very well. So we had to take her to the emergency room, and that's when they provided care for her. So they gave her antihistamine, standard treatment for allergic reactions, and some cortisone. So the next day, she wasn't feeling very well. She was drinking a lot of water. She was going to the bathroom a lot. She was looking very pale and no energy. And that's when I thought there's definitely something wrong, but maybe her body is trying to flush out the cortisone from her system because maybe it was just a high dose. So that night, she still wasn't well, and she expressed that she wanted to go see the doctor. I said to her, we were just at the doctor's yesterday. Let's wait till tomorrow. The next day, I brought her to the clinic, and the doctor assessed her and said she was fine. And my gut instinct told me something was wrong. So I said to her, just do a blood sugar check. And at the time, she said, well, the insurance won't cover it. And I said, please, just go ahead and do it. I'll pay for it. It's not a problem. And that's when they checked it, it was 650 milligrams. I was shocked. I thought there's something wrong. You know, the girl is running, she's playing, she's fine. There's nothing wrong with her. And I asked him to get another device. I said, your device maybe has an error. It has been calibrated. Let's do another check with another device. And that's when they did another check. It was also very, very high, 650, same reading. And that's when they decided they needed to admit her and do some blood tests. So we went to the emergency room, and it was, we were waiting for the results. And that's when the doctor came and said, your daughter has type 1 diabetes, and we're going to admit her to do some further tests. And it was such a shock because we were not expecting to be, told that our child had a lifelong chronic condition. Diabetes, it involves insulin injections, external insulin injections. So it came as a very, very huge shock for us. And she was admitted, and I have to say that the healthcare providers did their best. I didn't have a very good experience with the diabetes educator. I felt that she could have been giving me more information at the time. And I felt that she needed to be a little bit more compassionate with me because I was very traumatized. This was my youngest child who now has to. So I was given a sheet of 4 pages, and it was 4 pages of text. And I was told, okay, off you go home and go and manage your daughter's condition. She taught me how to give an insulin injection on an orange, and how to check a blood sugar level. And I was off to fend for myself as such. Ibrahim was a different experience with him because he had been on a school trip. He was away and he was traveling, and he fell ill when he was there. They thought he had a flu. So they brought him to the emergency room, where again, they gave him, dextrose, they gave him cortisone and put him on the flight. During the flight, he became very, very ill. He went in and out of consciousness. They gave him more sugar and water to keep him conscious. Again, not knowing that he had high blood sugar and making his sugar even higher. When he landed at the airport, that's when my eldest son, who went to pick him up, decided, please do a blood sugar check. because his sister has diabetes. And that's when they did a blood sugar check and they realized it was high. We went to the emergency room. Again, it was very chaotic. I was very traumatized because he was so critically ill. And the doctor, was trying to, I was screaming and I was, please save him, please help him. And you had to go wait for the insurance approvals. You had to, there was a process, and the blood test took a long time. They didn't have a lab in the emergency room. They had to go off to the main lab. And basically his electrolytes were extremely low. He was extremely dehydrated. And I mean, at the time, I was so angry. I was like, just give him insulin, not realizing that had they given him insulin, his potassium and magnesium would have gone even lower. So it was a very difficult, traumatic time. And then in the intensive care unit as well, they weren't. It was kind of, they were just in action. Nobody was giving me an update as such. Nobody was telling me what was going on, what the plan was. What they needed to manage. I needed to know what they needed to manage. So I didn't feel I was very engaged with Ibrahim in the diagnosis and understanding what was going on. I thought it might be type 2 diabetes. I didn't know it was type 1. So I had, because he was older, he was 17, I thought it might be type 2. Of course, hoping that he could just take a tablet and he wouldn't need insulin injections. So there was quite two very different experiences with each child, and both very traumatic.
Thank you. Thank you very much, Ms. Mariam, for sharing this story. Now, I would like you to tell us, from your point of view, what is the role of you as a mother or the role of a patient in improving diagnostic safety and preventing diagnostic errors or adverse events, from your point of view?
Thank you. That's a very good question. I think definitely engaging everyone in an open door policy with communication is very, very important. Definitely, you're dealing with a lifelong chronic condition where there's a lot of information that needs to be taken in. And especially at the diagnosis phase where they're not quite sure of what the condition is. They don't want to quite tell you. So they need to get you involved. They need to update you and explain things to you. And that will help with parents being more cooperative, patients being more cooperative. You don't understand why they're doing 3 or 4 blood tests in the day and causing pain and inflicting pain on your child. So if they explain things and tell you what the plan is and what they're doing and give you updates, that is very important. And it's important for the patient as well and the family to be assertive and to ask questions and to express their opinions and their concerns. And again, having that open door policy allows for that. It allows for the patients to approach the healthcare providers and ask those questions and express those concerns. Another method that healthcare providers could perhaps use is in getting them more involved in the diagnosis is encouraging patients and their families to write down their concerns, because they might not remember them at the time. And writing down as well helps the parents probably summarize the information in a method that they understand. And then when the time is right, they'll remember to ask those questions and they'll remember to express those concerns. So communication is very important. It's a reciprocal relationship. So again, the patient as well needs to express and reveal and be very transparent and honest about all their family history, the signs and symptoms they observed. All that can help with the diagnosis, because maybe there's another underlying condition. And maybe it's a genetic cause, because there's several types of diabetes. So it might not be type 1 diabetes. If, for example, the mother or father have type 1 or the grandparents have type 1, it could be something called MODY. So it is important that, both sides are transparent and honest and open in their communication, and really listen to each other. That's also important, that the healthcare providers are listening to the patient and the patient is listening to the healthcare providers as well. So that mutual and reciprocal relationship is very, very important, because it's the beginning of a long-term and long-term chronic condition, and where a lifelong of care.
Yes. So thank you very much. You shared with us what the patients or the parents can do to engage themselves or to empower themselves and to be an active role in the health care system during the diagnostic process. And also you mentioned some parts that the healthcare providers can do and in regards to engaging those patients. Do you have any other points that you want to deliver a message to our audiences, which are most of them are healthcare providers, to help their patients be part of the healthcare system and to activate their role? So you mentioned listening to them. You mentioned engaging them in every step in the diagnostic process. So do you have other points regarding the role of healthcare providers in engaging their patients?
That's also a very good question, because it is a reciprocal relationship where both parties need to be engaged, both parties need to be involved, and the main goal is to get parents of children with type 1 diabetes to manage the condition, to what they call self-management, where they will manage the condition. And engaging the parents in the process very early on, even at that diagnostic phase, is very, very important, because they have to learn all these skills, they have to take in all this information, and they need to know it before they leave, because they're going to go home and they have to manage their child. So definitely maybe using more of a hands-on approach, engaging them in what blood tests they're going to be doing for the rest of their lives, and discussing what those medical acronyms mean. What does it mean? What does a blood sugar level of 350 mean? And what are the consequences of it? What does a blood sugar level of 70 mean? And how to deal with those. If it's low or if it's high, how do you deal with that? And that needs to be activated at the diagnostic phase very early on, so that the parents go home with the skill set that they need, and they feel that they are knowledgeable and they are able to manage their child's condition, and they are engaged in the process, that they don't feel that they are, they have the lack of knowledge, or they have a lack of confidence in themselves. So that is very, very important. Another thing that is important is discuss the plan throughout the process. So from the time they're admitted to the time they move to the room, have that plan and have that reciprocal relationship where you are discussing what's the next step, why we're doing this test, why we are, what tools you're going to need for the next step when you go home. And that really, really helps, because then the patients know exactly what to expect, and they become more engaged, they become more cooperative, and it helps them feel, yes, I am empowered. They have empowered me with the knowledge I need and the skills I need. And once you're empowered, you can reach the phase of self-management. And that is the goal, is that you go home and you feel you can manage your child's condition, you feel confident. And so yeah, it's that reciprocal relationship of listening and finding out the skills, to come up with a plan of the skills the parent needs, the skills that and give them the opportunity to ask those questions and express their doubts. Yeah.
Yeah, so having the patient activated or engaged during the diagnostic process, as we agreed on, is very important. And based on your experience with your two children, it was vital to the psychological status of you as a mother, and also the end result of having the correct diagnosis. Any additional engagement tools that you as a patient experienced other than in the diagnostic process that you feel is important to share and to deliver to our audiences, and you want to advise them with, from your point of view as a parent or as a patient
I
here?
think I think definitely, because the patients they eventually, with time, they become the experts as well. So involving them in the tools that they need when they go home is very important. As I mentioned with Noura, they gave me 4 sheets of text. In an emergency, there's no way I was able to find the information I needed in those 4 sheets of text. So having, for example, flow charts, easy, quick, easy to read. If the blood sugar is low, do this. and then measure this and make sure that it goes up to this. That's very important, that it's a tool that people can actually use, that it has been tried and tested, and both parties, the healthcare providers and the patients, have been involved in the process. That's very, very important. Another important thing is support groups. So it's important that parents get the support they need from the healthcare providers and peer support from other mothers, maybe with children with type 1 diabetes, and that it's in a setting that is evidence-based and where no misinformation is shared, because that is a big problem. There's a lot of misinformation out there. There's a lot of people who have different ideas. We have a very high population of diabetes. So type 1 diabetes is very different from type 2, and the methods of management are quite different. So it is important that that space is available to parents and to healthcare providers, and it gives them that space where they can both share that information and see how they can help parents better and make them more independent and reach that goal of self-management more easily. Definitely, those are key aspects. So yeah, getting the patients involved and the healthcare providers in focus groups, in several focus groups with feedback sessions to see, developing the tools that they need to help them. That's also very important.
So co-developing, co-designing materials or policies will help engaging the patient and having the perspective of the patient. Thank you very much, Mariam, for being here and sharing your story. It was our pleasure and our honor having you here. Thank you very much. Now, yes, see you soon, and hopefully you're going to have a safe journey with your children.
Thank you very much. I appreciate it. Thank you.
Many thanks to Mariam for sharing her story. Now moving on to our first speaker, who will speak about patient issues along the diagnostic journey, which will be a presentation done by Mr. Hussein Jeffrey and Ms. Helen Haskell. Mr. Hussein Jeffrey is the founding director of the World Patient Alliance, a global patients alliance. He has been very active in the field of patient safety and has been the former vice chair of advisory group of WHO's Patients for Patient Safety program. Hussein has also founded Pakistan Patient Safety Initiative and has been working towards several patient safety initiatives. And Ms. Helen Haskell is the president of the American nonprofit patient organization Mothers Against Medical Error and Consumer Advancing Patient Safety. Since the medical error death of her young son, Lewis, Helen has devoted herself to enhancing the patient contribution to safety and quality in all aspects of healthcare, including medical error prevention, medication safety, diagnostic accuracy, rapid response, and response to adverse events, among others. Welcome, Mr. Hussein, and welcome, Ms. Helen.
I will open the presentation. I'm Helen Haskell, as Lamia said, and we are here to talk about the diagnostic journey and what it means to patients. So just to sort of set the stage, every diagnosis is a journey, as we all know. Some journeys are short and simple, some of them are long and complicated, and some end more happily than others. But patient involvement to one degree or another is key to good outcomes in all of them. So what we want to talk about today are patients and families' perceptions of where the gaps lie in our diagnostic processes and what patients think a good diagnostic process should look like. Next slide, please. So I want to start with a definition. You've probably seen this more than once over the past day and a half, but this is the definition from the 2015 U.S. National Academy of Medicine report on diagnosis. It was considered quite revolutionary in 2015 because it made communicating the diagnosis to the patient a requirement for an accurate diagnosis, which was something that had not really been said before. But patient engagement was on the rise in 2015, and within a couple of years, this definition began to feel as though it was not inclusive enough of the patient and the patient's perspective. Next slide, please. So now we like to think of diagnosis, as Miriam said, as a co-produced, co-developed enterprise in which the patient's input and understanding are actively and explicitly sought. An interaction. Two areas that are presently of great interest to patients are the rationale for the diagnosis, making sure the patient understands your reasoning in order to confirm that the history is correct and that you're both on the same page going forward, and uncertainty, the idea that diagnosis is more often a probability than a certainty, that diseases and diagnoses evolve, and that the patient should be educated to be on the lookout for any changes that might warrant a change of course. Next slide, please. Now I'm going to turn it over to Hussein to talk about some of the concerns that patients have around diagnosis. Hussein, you're on mute.
Just a second. So yeah.
You're,
Can you hear me?
yes.
Yeah, it's all right. So yeah, thank you, Helen. And there are a number of concerns that patients have at the time of diagnosis. The literature shows that a large number of patients describe hierarchical relationship with physicians. Research also shows that many patients also describe physicians as authoritarians, so they feel powerless in many healthcare settings around the globe. They fear that if they ask for information or raise any questions, they will be seen as difficult or complaining patients. Moreover, patients are often unfamiliar with the healthcare system and do not know how to navigate their way around. They have minimal knowledge about the diagnostic journey, which is like an unknown destination. Health literacy is also an issue, and patients do not always know when to see the doctor, and many times they reach the healthcare facility quite late as well. The patients also face difficulty in dealing with inexperienced or even incompetent healthcare providers who try to appear experienced as well. Next, please. Okay. So, patients in low and middle income countries have added concern as compared to patients in the developed countries. Access to a doctor or an appropriate healthcare providers could be a challenge in some of the low and middle income countries, which could hamper the chance of an appropriate diagnosis. And this lack of access to a doctor or an appropriate healthcare provider then leads patients to alternative practitioners who often do not have the required qualification, skills, or the healthcare services to provide a proper diagnosis. And then issues such as financial constraints or access to appropriate health services also stop patients from reaching the doctor and getting a diagnosis and treatment for their condition. Lack of health literacy, low education levels, and underconfidence of patients also hinder the ability to communicate well with the healthcare providers. Lack of communication is also a problem for the patients to effectively basically communicate. But we must also remember that a large number of healthcare providers also lack good communication skills, and at times these healthcare providers do not even intend to communicate at all. And time constraint is also a big problem where patients do not get enough time with the doctor, and getting a good diagnosis in the available time is again an issue. Patients at times have minimal knowledge about their diagnostic journey, and they often do not necessarily know what information is valuable for diagnosis or when they should be concerned that the diagnostic is off track now. Next slide, please. So, how can really patients contribute? Patients can do a lot to help with the good diagnosis. The actions that could help physicians in reaching an accurate diagnosis include several communication-based actions, such as telling one's story well, being a good historian, and keeping good records. Experts value the patient's history as a critical component of proper diagnosis. It is important that patients play an active role as informed consumers and are ready to take care of their health. In case of multiple healthcare providers, the patients could also facilitate communication between these different healthcare providers like nurses and paramedics and all of them. Patients must also ensure that the test results are even, are seen by the healthcare providers. And again, patients must take charge and ensure follow-up with the healthcare providers and do not assume that no news is good news. Now I hand back over to Helen.
Next slide, please. Thank you, Hussein. Now we're going to introduce you to some of the real-life cases where the diagnostic process did not go well. These are cases as told by the families themselves, and you'll hear some of their opinions about how things could have been done better. Next slide, please. First, I want to orient you to something else you've probably been seeing a lot in this conference, the National Academy of Medicine diagram of the diagnostic process. I won't linger on this, but it starts with the patient engaging with the system, goes through all the process with patient and provider, and then goes on through to outcomes. Next slide, please. So this is another slide showing where failures occur in the diagnostic process. It's very high level. I think I would have added a little more to this list if I had been making it. But as you can see, it's all across the continuum. And the continuum refers back on itself. So I'd like you to keep this in mind as we go through the following cases. Now I'm going to give it back to Hussein to tell you about our first case. Next slide, please. Are you on mute again, Hussein?
You can't hear me?
No, you're fine.
Yeah, I think. All right. So we have a number of case studies, to present to you different aspects of diagnosis issues and how patients get caught in all of this. So let's start with the first one. A 12-year-old Jessica began having mysterious fainting spells. A neurologist at a leading children's hospital diagnosed her with epilepsy, but the prescribed medicine didn't help. 4 years later, her grandmother read about long QT syndrome, a heart rhythm syndrome that can cause fainting. A long QT rhythm had shown up on one of Jessica's first electrocardiograms. Jessica's mother took the ECG printout to the neurologist, but he thought it was not significant since the same rhythm did not appear in other tests. The family requested a full cardiology workup, including a Holter monitor test, which records heart activity for 24 to 48 hours. The cardiologist reported back that all the tests were negative for long QT. 10 months later, at age 17, Jessica died of long QT syndrome. The family learned that the 5 of her 7 test results had been misread and that the cardiologist had never seen the Holter monitor test because the paperwork got lost. Jessica's physician told the family that they would have not changed their course of treatment. The family found this distancing and denial especially very painful. So next slide, please. Okay. So let's discuss what went wrong in Jessica's case. Did the doctor have a preconception that a teenage girl would have a propensity to psychometric illness? Jessica's mother said it felt like they all agreed early on that Jessica didn't have the long QT syndrome, so no one tried finding it. The neurologist did not look into long QT syndrome, even though the family brought it to his attention. Long QT syndrome can be intermittent, but the doctor did not double check his assumption that an isolated positive test was not significant. The cardiologist misread Jessica's ECG. The medical examiner who did the autopsy cited a study showing that electrophysiologists have much better success at detecting long QT syndrome on ECGs than cardiologists do. In a highly reliable diagnostic process, deference to expertise should be a cardinal sin. When the paperwork for an important test was lost, the doctor told the family the test was negative instead of asking Jessica to repeat it. The doctor feared liability and did not try to learn from the experience. Now I had to hand it back over to Helen for the lessons learned from this study.
Next slide, please. So some of the lessons. Well, first of all, I think is that diagnosticians should guard against preconceptions about any individual patient. Even if a preconception is grounded in probability. No population is uniform. Another is that the family often has valuable knowledge to contribute to the diagnosis, including research. Research by family members can be accurate and helpful, as it was with this family. Families should be encouraged and guided as to reliable sources for research because the family has the time and the motivation to do in-depth research. And given proper guidance, this can be a valuable partnership. The differential diagnosis, which is so important to diagnosis, should be maintained and revisited when treatments don't work, as in the case of Jessica. And patients should be asked to repeat tests when the results are unavailable and inconclusive, which in my experience, they often are not. And finally, transparency with families about misdiagnosis is the first step toward prevention of future errors. Next slide, please. So just to give you all a few resources and sources on these, some of these points, Pat Croskery, a Canadian researcher who's the expert on unconscious bias and diagnosis, points out that we all have unconscious biases and that we need to maintain constant vigilance to contain them, like a wary animal. He suggests avoiding snap decisions, paying extra special attention to the workup for patients for whom you harbor strong feelings, positive or negative, or doubts about their veracity, and reflecting and arranging to get regular feedback from your colleagues on your diagnoses. Next slide, please. And diagnostic error is one of the most common causes of medical harm. And lack of openness from providers is a cause of great distress for families, especially in a case like Jessica's, when longtime doctors turn away. The Candor program from the American government agency AHRQ is one of a number of full disclosure programs that are available to try to bring healing and learning from harm in a systematic way. Next, we'll hear about our next case from Hussein. Next slide, please.
Yeah. So our next case study is about Mr. Mahmood, who had retired from service 8 years ago and lived with his son and his family. He started behaving very oddly as he would meet people, visit places, and take meals, but then forget about it. His grandson, who was raised by Mr. Mahmood, took him to a GP who said there was nothing wrong with him at all. So Mr. Mahmood's condition gradually worsened and problems in the family began. He would eat food and reprimand not giving him food on time. If he was given food again, then his tummy would go loose and he would dirty his clothes and his room and surroundings as well. He was shown to multiple doctors, including specialists, but they all concluded that there was nothing wrong with him. His family discussed the issue and came to a conclusion that it was an attention seeking behavior, as he had retired from his service and had nothing else to do. His food was rationed so that he could not dirty his clothes. Moreover, he was also excluded from all family affairs and was limited to his room. A man over 85 kgs of weight was reduced to 65 kgs in a matter of under 2 years. His condition and situation at home further worsened, and he was admitted to a mental hospital where he was finally diagnosed with Alzheimer's disease. Next slide, please. So, there are some different questions that are come out of Mr. Mahmood's case. Why did doctors miss what should have been an obvious differential diagnosis in an older person? So I think dementia and Alzheimer's is becoming very, very common. But even then, I think it's come to the competence or the training of doctors as well that they couldn't pick up dementia. Was there a misleading symptom or absence of symptoms? There was none. Did they explain their reasoning to the family or tell them symptoms to watch out for? Because they didn't suspect, they didn't ask for any symptoms to look out for to the family as well. Why did the family consider the absence of diagnosis to be definitive as his condition worsened? And did Mr. Mahmood's life improve after finally getting a correct diagnosis of Alzheimer's disease? Yes, his life actually improved significantly once the family had the complete diagnosis and they had the information on how to look after Mr. Mahmood. His quality of life, increased tremendously. Over to Helen for lessons learned from this case study.
Next slide, please. So some of the lessons from this case are that it's always important to have a differential diagnosis, as we said earlier, and to share it with the family. The clinical skills of doctors are critical in making a correct diagnosis, because a wrong diagnosis can lead to devastating consequences for the patient and family. And the disastrous psychosocial ramifications of an incorrect or delayed diagnosis are often not noticed or ignored. And a diagnosis often reveals itself as the disease evolves. The family should be alerted to changing symptoms to watch for. And diagnoses should be revisited when a patient doesn't improve. And a long-term relationship with a single doctor allows a patient's deteriorating condition to be noticed and diagnosed. And that may have been one issue with Mr. Mahmood, because his family took him to a number of providers and not back to the original GP. Next slide, please. So I just want to give you a few resources again for something like this. I think a major factor in Mr. Mahmood's diagnosis was lack of patient and family engagement. And AHRQ again has valuable resources in patient engagement. These are patient forms that can be filled out before going to the doctor to help ensure that your communication is clear and your thoughts are organized. Next slide, please. Next slide, please. And this is a patient checklist from the Safer DX series. It's intended for going over doctor's notes, which are available to patients in the US, but it's also a valuable means of making sure that all the bases were covered in your appointment. Now Hussein is going to tell us about the next case.
Next slide, please. Yeah, thank you. So, 19-year-old Kevin was referred to an orthopedic consultant for back pain. His blood tests revealed abnormally high levels of calcium. When writing to the GP, the consultant underplayed the high calcium levels and ignored plasma creatinine level indicative of more than 50% loss of overall renal function. Kevin repeatedly returned to the GP. A blood test after 2 years showed his calcium levels had risen even further. The GP wrongly diagnosed leptospirosis, a bacterial infection, and referred Kevin to a hospital without mentioning the high calcium levels. The practice nurse wrote the blood results on a post-it note, which became stuck to the back of a referral letter and was not seen by the admitting hospital. All the evidence indicated that the patient was suffering from a solitary parathyroid adenoma. Surgery would have been curative and with a normal life expectancy. But the standard blood test did not include calcium in that particular hospital. So the hospital remained unaware of Kevin's dangerously high calcium levels, and a diagnosis of nephritis was made. As the condition worsened, Kevin was transferred to a tertiary level hospital. Senior doctors were not involved in the care, and no alarm was raised as Kevin rapidly deteriorated over the weekend. Kevin died 3 days after the admission at the age of 21. Next slide, please. So what went wrong in Kevin's case? Kevin's diagnostic course was marred by incomplete communication at all and every step of the way. Doctors appeared to have been blinded by preconception that severe illness was unlikely in an otherwise healthy looking young man and did not take his symptoms seriously. No one looked holistically at his multitude of abnormal symptoms and test results. Kevin doctors appeared to suffer from confirmation biases, downplaying symptoms that did not fit with their initial diagnosis. They then relayed the assumptions to each other, with the result that information that might lead to other conclusion was lost. This is an unfortunate combination of medical silos and individual cognitive biases. Next slide, please. And over to Helen for the lessons learned.
So, this case is a perfect demonstration that patient transitions between healthcare providers are a point of high risk of miscommunication. Kevin's doctors were communicating with each other, but they were not doing so systematically or effectively. The failure to rescue as Kevin deteriorated in the tertiary hospital was also a diagnostic failure, and one that probably had its roots in uncritical acceptance of earlier misdiagnoses. Family access to a medical emergency team or a critical care outreach nurse could have made a difference during this critical time. And Kevin's parents, like Jessica's, were distressed by the lack of learning among those involved in his care. When one junior doctor commented to them that Kevin was just unlucky, they turned to litigation. So, what can be done to bring about learning from disastrous misdiagnoses like Kevin's? This is about more than simple apologies. It requires a learning system that's set up to use both good and bad examples of diagnosis as a means of improving care. Next slide, please. So here are a couple of resources that I think might be helpful in cases like Kevin's. Structured handoff programs are the first step toward improving communication between providers, which is a frequent source of diagnostic error. The IPASS program in the US is one of the best known of these programs, with a simple mnemonic checklist to help both parties include the most important elements. Another important safeguard is allowing patients access to their own records so that they can see if important information has been sent or received and that it's accurate. Records in most countries aren't yet open, I realize, but they are in the US. And the Open Notes Project, which has been operating in the US for many years, can provide assistance and advice globally on helping patients access their notes and helping providers help patients access their notes. Next slide, please. Next slide. There we go. Another relevant area in this case is communication with the patient and family. Kevin died in the hospital when no one recognized how seriously his condition was deteriorating. One resource to help enlist families to prevent this kind of tragedy is family-centered rounds, where the report on the patient's done at the bedside so the family can participate and express concerns. Family-centered rounds are widely used in children's hospitals especially, and they've reduced medical errors significantly. Another resource is patient-activated rapid response teams, giving families a number to call if a patient deteriorates unexpectedly. This example from the Royal Berkshire Trust in England has had outstanding success using a critical care outreach model. All of these resources, everything that I've mentioned, is free online. Now back to Hussein for our next case. Next slide, please.
Yeah, so this is case of Mrs. Fatma, who had been referred by her GP for an ultrasound to investigate the possibility of gallstones due to an ongoing upper abdominal pain. The GP, however, omitted to mention suspected gallstones in the referral note. Fatma was the wife of city's mayor. The staff at the radiology department of the hospital decided to add an abdominopelvic multiphase contrast CT examination to provide their most discerning service, even though it is not advised by national clinical guidelines. During history taking, Fatma had told the hospital staff that she was not pregnant, but omitted to inform that she was receiving an ongoing IVF treatment. Less than a week after the CT scan, she was informed by her obstetrician that she was pregnant. She was delighted until a friend told her that if pregnant at the time of the CT scan could have harmed her embryo. Later, the loss of the embryo was confirmed. Next slide, please. Yeah. So what went wrong in Miss Fatma's case? This is a case of over testing, giving more than what is needed to obtain the diagnosis. The GP did not adequately communicate his concerns. The radiologist did not know what exactly they were testing for. So perhaps decided a cast a wide net, even though Miss Fatma had been referred for an ultrasound and not a CT scan. This also appears to be a case of VIP syndrome, the desire to provide top of the line services to very important people like Mrs. Fatma, who was the wife of the mayor. VIP syndrome can cause harm. And in this case, this excessive testing caused the loss of a very much desired pregnancy. The question arises, would an average patient have been given a pregnancy test before scanning to verify that her answers are correct? And Fatma was not warned that a CT scan could harm a potential embryo, which would have probably led to her giving a different answer altogether. Over to Helen for the lessons learned.
Next slide, please.
I would just like to remind you we have 5 minutes left.
Okay, thank you. So poor communication between providers is a common problem, even for VIP patients. It's helpful for patients who usually speak to providers on both ends of the discussion be told in clear terms what test is being ordered and what it's for. Overuse of diagnostic testing is a widespread problem. While people usually think of testing as a benefit, it can cause harm in multiple ways. Giving patients critical information about risk is an important prelude to testing. Did the radiologist not see that Mrs. Fatima was pregnant when they read the scan? Because apparently they didn't communicate this to her. And another question I can't help wondering about, was Mrs. Fatima's abdominal discomfort a symptom of her pregnancy? Was there an earlier misdiagnosis? Next slide, please. I'll go through these quickly, but there are a couple of resources I thought were particularly relevant to this case. AHRQ has a diagnosis-focused referral form that's part of its new Team Steps program for diagnosis. This form is simply a form to capture in writing what the referring clinician is asking for and why. It can be transported by the patient to be sure that everyone is in the loop. And for anyone who has further interest in the concept of the VIP syndrome, this is a quote from one of a number of articles that lays out the perils of VIP care in some detail. Next slide, please. So this brings us to the end of our patient stories. As you may have noticed, there are a number of common themes and patterns that emerge in even this small sample. They include miscommunication and lack of collaboration between providers and between providers and families. One of the surprises to me was the prominence of issues with diagnostic testing, including overtesting, undertesting, poor interpretation, poor relaying of test results. Another common theme was preconceptions and biases, both positive and negative, about certain groups of people, especially what I call the healthy patient bias, the slowness to diagnose illness in a young, well-nourished looking person. We've discussed the systematic process, lack of a systematic process of differential diagnosis, and not returning to reconsider the diagnosis when symptoms persist. And finally, there's the reluctance to acknowledge and learn from mistakes, which is a phenomenon that's almost universal in healthcare, meaning that all of us are slow to find out about common misdiagnoses. Next slide, please. And I just want to return just for a second to this diagram. You can see that even in just 4 cases, there was almost no part of the diagnostic process that remained untouched by some kind of breakdown. Diagnostic error is hard to avoid. It'll take a systematic effort across the system to change that. And as I hope you've seen, patients can and should be an important part of the process. Now I'll leave the last word with Hussein. Next slide, please.
Yeah, so these are the key conclusions of the presentation. All along the diagnostic process, there are many opportunities to improve diagnosis through improved communication and continuity of care. Even the most highly educated people have unconscious preconceptions and biases, and assumptions and premature conclusions are common pitfall in diagnosis. Greater involvement of patient and caregivers at every point provides a strong safeguard against diagnostic errors. And some of the best tools for improving diagnosis are structured communication, careful listening, and respectful conversation with and between healthcare providers, colleagues, and the patients. Next slide. Next slide, please. Yeah. So with this, myself and Helen, we both thank you for this opportunity, for your patients listening. We are extremely grateful to Saudi Patient Safety Center as well for providing us this opportunity. We have, our emails are there. If you have any questions, or if you want to communicate with us, please do so. Thank you very much.
Thank you.
Thank you very much, Mr. Hussein and Ms. Helen, for this presentation, amazing presentation. I would like to remind everybody, if you have any question, you can write it in the live Q&A chat box, so we can discuss it at the end of the session. Thank you very much, Mr. Hussein and Ms. Helen. Now, moving on to Dr. Kelly Smith. She will be talking about patient reporting of diagnostic safety. She is Associate Professor in the Institute of Health Policy Management and Evaluation, University of Toronto, as the inaugural Michael Guerin Chair in Patient-Oriented Research at the Michael Guerin Hospital, and Associate Professor and Co-Program Lead for Outcomes and Evaluation in the Institute. Her research focuses on co-producing practical solutions to challenges of healthcare delivery with a focus on patient safety and quality improvement. Welcome, Dr. Kelly.
Good afternoon, and thank you. I'm going to switch to my slides here in just a second. There we go. Perfect. Thank you so much. Thank you so much for coming and talking today and inviting me to speak about patient reporting and diagnostic safety. I've had the privilege of working with Helen Haskell for the past 14 years together as we tackle some of the big challenges and wicked problems of patient safety. And most recently, I've partnered with Helen and other patient partners on identifying different ways that patients are already telling us about their diagnostic safety experiences within the healthcare system. So I'm going to talk a little bit about that story today. So as we know, diagnostic errors are a leading patient safety concern in the United States. Most of the epidemiological evidence indicates that there are about 1 in 20 patients harmed every year from diagnostic errors in the ambulatory care setting in the United States. And when you think about that in terms of volume, with over 800 million provider encounters, that is a significant number of individuals who have a potential to be harmed through medical error and diagnostic errors in particular. In 2015, when we think about what we've learned from the National Academies of Medicine's report on improving diagnosis, what we hear is 1 in 3 patients will have personal experiences of a diagnostic error. In my own family, I've had much experience with diagnostic error, including losing a mother to a series of delayed diagnosis, misdiagnosis, and wrong diagnoses, which ultimately led to her death in 2018. So this is more than just a research area for me. It is a passion project for me to improve the care that we're giving and opportunity and reduce the opportunity for diagnostic errors in the field. What we've also learned more recently is about 33% of diagnostic-related claims include breakdowns in communication. That communication between the patient and clinician, we've heard multiple times today from Miriam's story through Helen and Hussein's cases, talking about the opportunities for improving communication. We also know that 79% of those diagnostic errors occur during the patient-provider encounter, creating a unique opportunity. And this is really where I've spent most of my efforts, looking at how do we improve communication between patients and their clinicians to improve the diagnostic safety of the experience and enhance that journey. So our big question that leads to this program of research is, how do patients report diagnostic safety breakdowns in the field? And what we've learned is pretty much any way they can. Our patients are looking to talk to us directly. They call us to tell us that things are not going well. They report it in claims, which is sometimes the only way that something gets handled. They tell us in surveys that they have had a breakdown in their diagnostic process. They may not use the same terminology that we use, but they certainly use words that are reflective of a breakdown in the process and in their journey of diagnosis. More recently, patients have turned to social media, having chat groups on profiles like Facebook. They post to Twitter. They use Yelp or other service industry reporting portals as well. So there's a lot of information that patients are already sharing with us. And our goal in my research team is to figure out how to better utilize and tap into this wisdom to improve the system of care that is resulting in these breakdowns. In 2016, with a grant from the Patient-Centered Outcomes Research Institute, we partnered with a team of patients and a team of researchers to really identify how we can learn from patients harm or harm created from the healthcare system along the diagnostic process. This was one of those exercises where we worked with patients to ask questions. What are their questions about their own personal lived experiences, about where care broke down in their diagnostic journey or their loved one's diagnostic journey in some cases? And this picture reflects some of that deliberation. And what we can see here is that patients had unique insights on the patient experiencing the health problem. Oftentimes, that is a black box for many clinicians or health system leaders. To understand a patient's identification of the disease or identification of a problem and their decision making into engaging with the healthcare system. So these are important facets, though, because they create an opportunity for breakdown, and they're centered around the patient and the patient's decision making on the diagnostic process. There are also challenges with engaging with the healthcare system that we can learn from. And these are some of the ideas around patients thinking that there may be limited access, they may have limited ability to pay, or barriers where you need to demonstrate you can pay before you get care, similar to what Miriam had talked about earlier today, that they were delaying treatment and delaying care to her very sick children until they checked the insurance. So we also see there's a lot of information around this middle cycle here around clinical history and interview, physical examination, diagnostic testing, and referral and consultation. Oftentimes, these are communication based and from our research. So really underlying, like, how can we improve it? How can we have a goal of enhancing the communication around this center cycle? So clearly there's something going on there that the patients are recognizing as a signal. It is part of their lived experience. What was also really interesting was having patients put things in around, information gathering. So maybe that whole idea of history taking, being a good historian, sharing that story clearly. Also on the working diagnosis side, um, you know, communicating that working diagnosis, your diagnostic hypothesis as a clinician is really important for patients. And oftentimes communicating that uncertainty of diagnosis. There was a recent JAMA article by Mary Dam and Carmela Crock from the UK or from Australia, where it demonstrated that this communication of diagnostic uncertainty helps to co-create and create that collaborative communication environment. Saying it you don't know is actually a very powerful tool for patients because it helps them to become more empowered and identify that they too have a role in the diagnostic process. Further out in the diagnostic process, you can see communication of the diagnosis. So many patients report having some challenges with understanding what their problem is. They may have treatment, but they don't fully understand what their diagnosis is, or they may be given a treatment as part of the process of defining that diagnosis. So ensuring that communication is clear, concise, and with action plans is really critical to help improving the diagnostic process. And then, of course, outcomes. Patients were able to identify opportunities to improve the health system and questions they had about that process as well. As Helen and Hussein talked about, this is the diagnostic error definition, and this really helped to set the stage for some consistency across the research world. It helped to ground individuals and individuals, researchers, health systems, to better attest to what kind of diagnostic breakdowns are happening. So there are key pieces of this definition that have been foundational to our work. And this is really that piece of accuracy. So having a missed diagnosis or a misdiagnosis or wrong diagnosis is that accuracy term. Timeliness is the delay in diagnosis term. And then this communication of that diagnosis to the patient becomes the most problematic part, because that information is often not captured in the medical record. How that was communicated, confirming the patient's understanding of the communication of the diagnosis. But what we do find is communication writ large contributes to breakdowns in both accuracy and timeliness of diagnosis. So it's not only an element of the definition, it is also a causal factor when you break it down from the patient's perspective that contributes to the diagnostic error or diagnostic breakdown. We also ended talking about our research from the perspective of breakdowns. We learned from clinicians, and when we co-designed our studies with clinicians and patients, what we learned is people are uncomfortable with the concept of error. And in order to make our research more receptive and people receptive to listening to some of the findings that we had, we term our work around patient-perceived breakdowns in the diagnostic process. And from that perspective, we can start that opportunity for dialogue and start the opportunity for shared learning experiences. When we couch it as patient-perceived breakdowns in diagnosis, we tend to get the best uptake of the information. People are more willing to listen to the outcomes from the patient's perspective, and then look at the system and see for the opportunities for change. So part of our research was coming up with a taxonomy, or a way for us to categorize information from patients all the way through the diagnostic process. So we included elements from the patient experience as a health problem to engaging with the health system. We broke down the center of this cycle, although we did also have some information around working diagnosis, information gathering, and information integration and interpretation, although that's fairly rare from the patient's perspective. A working diagnosis statement might be, I didn't really know what my diagnosis was, or why they asked me to come back in 2 weeks if my medicine wasn't working for that particular problem. So those were the signals from patients that maybe the individual didn't share the working diagnosis as part of their communication strategy. We also looked at different ways of individuals' information coming into the system. So we looked at health systems, and I worked at the time of this, initiating this work, I worked at a large health system in the United States with thousands upon thousands of reports from patients. These reports from patients were in the way of a patient experience survey that had open, free text comments. And I thought to myself, I wonder if the patients are actually using those free text comments to tell us about their diagnostic experience. So we started to look at how can we operationalize the diagnostic process to learn from these surveys? And our team worked with patients. We worked with Helen to help us identify opportunities for improvement along the site, how we should code, what we should look for as a potential signal in this work. So we started with urgent care. Our urgent care settings at the time, we had 9 urgent care settings, and in a year we had 7,245 completed surveys. So a fairly large sample, a little bit too large to start with, to be honest. And so we tried to discuss, why would urgent care potentially be an opportunity for improvement? Why do we think that the signal might be there from patients and families? And urgent care has a unique aspect in the United States, and we call it a serial episodic care. So individuals tend to go to urgent care if they don't have access to primary care, particularly on the weekends or outside of evening hours, opportunities where, maybe it's not as emergent as sitting in an emergency department for several hours. So they attend urgent care for sort of just-in-time primary care type related things. However, there's also a misunderstanding. The term urgent as part of that urgent care setting often thinks that patients go there with almost emergent problems, things that they may have been better off seeking care at an emergency room, because urgent care settings aren't often equipped as an emergency department. They're staffed by primary care clinicians oftentimes, and oftentimes there's a mismatch between the expectation of what the patient is expecting and what the actual clinic can provide. So we thought, if patients are telling us anywhere about diagnostic concerns or diagnostic errors, it's going to be in urgent care. And what we did find is that we focused on the negative comments, thinking that individuals who are commenting negatively about their experiences in urgent care are more likely to have a breakdown in the diagnostic process than are people who are speaking positively about their experiences. So we looked at over 1,630 negative sentiment comments and coded them around the diagnostic process. And what we did find is that of those 1,600 cases, there were 328 comments related to individual patient comments or individual patients who recognize a breakdown in the diagnostic process. So clearly there's some signal here. This represented about 20% of the overall sample, 7.6% of the sample with surveys, and about 4.5% of the total survey samples. That was kind of enlightening for our team, because that number is about that 1 in 20. 1 in 20 patients experiencing a breakdown in the diagnostic process. 4.5%, 5% of patients recognizing and reporting back to us that there was a breakdown in the diagnostic process. So we were onto something, and pretty excited to learn that patients were already telling us that there were opportunities for improvement. What we also learned is that our breakdowns were categorized into several buckets. The first bucket was accuracy, those wrong diagnosis, misdiagnosis, or misdiagnosis, timeliness, rate of delay in the diagnostic process. And then there were a few cases of communication, although that was really difficult to tease out because of the definition of the diagnostic error, where it's communication of that to the patient. So those are where we learned about, patients not really knowing what was wrong with them when they left. And so opportunities to unpack what is behind these diagnostic breakdowns are opportunities for improvement in the health system. Communication was clearly underpinning many of these. And so it was an opportunity to learn the language of diagnostic safety from the patient's perspective as well. So these are some of the words that patients were using in that first sample. I had a missed diagnosis. my diagnosis was incorrect. Get the diagnosis correct. Proper diagnosis and care. Misdiagnosed and incorrectly diagnosed. One patient's family member had actually attached a request for medical records, a request for a claim, a request for a meeting with the health system to their survey as well. And that articulated fairly clearly that they thought there were several breakdowns in the diagnostic process of their loved one. So our first lesson learned here was patients are telling us about these diagnostic breakdowns. We just don't really have a good way to utilize that information yet. So colleagues of mine and Helen, have created a survey, and they looked at online surveys eliciting diagnostic experiences. And from those surveys where they're actively eliciting information on diagnostic breakdowns, we learned that there are quite a few diagnostic error responses, and most of those had detailed narratives of those individuals who decided to tell us more about their diagnostic safety or diagnostic error experiences. What we learned that it was about 73% described problematic behavior by clinicians during the diagnostic process. And that was really grounded in communication. Patients really tell a signal of either lack of listening, rude communication, dismissive behavior, and those are signals to the patient that something's not quite right in their diagnostic process. And the conclusion of Traber and Helen in this particular study was that disrupted communication due to clinician behavior may be a more common contributor to diagnostic error than previously thought. This was one of the first published studies on this sort of unique experiences from the patient's perspective, garnering information around diagnostic error from patients who had been harmed from medical errors and diagnostic breakdowns. So eliciting these diagnostic experiences through online surveys works. We can get information. People are willing to tell their story. And our goal as health system leaders needs to be linking that story to improvement. As part of this, the growing evidence base, Traber also worked on some of the patient complaints. Dr. Giardina and team looked at patient complaints as a potential source of signal. And here they found some really interesting information where they compared what the patients were telling us in the complaints with the medical record. And when you distilled it down, what we learned from this exercise was that while patients may be signaling challenges in their diagnostic process, few of those challenges are captured in the medical record. And when you think about it, it kind of makes sense. We oftentimes don't recognize that we are bad communicators, right? We oftentimes don't realize that being rushed through an encounter or coming in and we're slightly distracted because we're worried about the case we just had or the case we're going to, or we're worried about something that's even outside of the healthcare system, things that are going on at home. Bringing all of that together, that doesn't make it into the medical record. The medical record is a medical record. It's from the medical perspective. So when we use medical records as a gold standard, we're actually diluting the opportunities for improvement because we're ignoring the patient's perspective on how that encounter worked, what actually worked, what didn't work in that communication, and what was left out. So an opportunity for improvement is a way to better engage and tap into the wisdom of patients in a more structured way, or in a way that we can leverage and utilize for improvement. Our team has more recently pulled together some additional information on patient-reported experience surveys where we took a broader look at ambulatory care. And what we learned here was, again, with over 3,000 cases that we coded individually, there are a lot of opportunities for breakdown. There's most patients who report a breakdown in accuracy and timeliness, or timeliness and communication, or accuracy and communication. It's not one or the other. It's generally a confluence of multiple of these. But what we do learn is that, again, a lot of signal in ambulatory care, and most of this signal is coming from communication and breakdowns in communication across the diagnostic process. We also recognize that patients signal our breakdowns in different ways, and those ways are happening right from the experiencing of the healthcare problem, challenges with entry to the problem, things that are also lagging that we don't get in the medical record, like the effectiveness of treatment or the treatment breakdowns. Because sometimes if a treatment breaks down, a patient assumes their diagnosis was incorrect and they go somewhere else for their care. So our fragmentation, at least in the United States, the fragmentation of care is contributing to our limited ability to learn from these cases, because if a patient feels they've been misdiagnosed or had a delay in diagnosis, they're probably going to seek care from someone else in a follow-up. So it's an opportunity to think about how we share information across settings in order to learn from our diagnoses. In this study, we also looked at, there were, again, quotes across the thing. We also added treatment in here. So treatment was a key area of breakdown or recognition of a breakdown in the diagnostic process. So just lack of information or explanation. So the physical exam was another key area of breakdown that usually isn't reported in the medical record, surprisingly enough, where the doctor visits, phone doctor visits, and this was when we rapidly turned to telehealth early in the pandemic. The phone doctor visits do not take the place of a doctor visit in the office. No physical exam of any kind, no check of vitals except for blood pressure, and only because they had it at home. So these were kind of signals that maybe there's an opportunity for improvement, to explain to patients that maybe they don't need a physical exam at every encounter, and that the phone visit was really to screen them to see if they needed to come in physically and have a physical examination and to enter the system again. Oftentimes questions. So he spent 5 minutes with me and made a determination without looking at my scan or what the other physician determined about my ear. So clearly they're sent out for testing, they're sent out for referrals, and there's limited exposure from the patient's perspective to how that information is integrated into a diagnostic concern. Oftentimes what we hear from patients is a limitation in communication, a limitation in listening, and limitation in information gathering and interpretation from all of that confluence of information. There's also breakdowns in the diagnostic testing process of, I never knew what my outcomes were. I followed up and nobody ever called me back. So lots of potential opportunities for improvement from a systems perspective to learn from what patients are experiencing and apply our ability to learn from those. Another question that I had around these surveys, these patient experience surveys, was, can we learn from this qualitative data, these open comments? Clearly there's a signal there. How do these relate to the other items on the surveys, those closed-ended questions that we tend to get paid for when we do well? There are incentive payments if we do well on those questions. So, and they're a little bit easier for health systems to do. So our team looked at both the qualitative work here. We coded all of the diagnostic errors, and we wanted to see, can any of these items on the survey, the closed-ended items, predict a diagnostic breakdown? And what we learned is,
Dr.
you bet.
Kelly, I just want to remind you we have 2 minutes left. Thank you.
Thank you. I'm almost finished. Thanks so much. So what we did learn is that the average provider score of 50 or less on these surveys, if a patient reports their provider score of 50 or less on the survey, the patient is 6.5 times more likely to perceive a diagnostic breakdown. Women are more likely to report a breakdown than men. And the average practice-related score of 50 or less, you're about 2.5 times more likely to have a diagnostic breakdown. So this may provide opportunities for improvement in the system in a more structured way, and our team is currently looking at that. So overall, our lessons learned are that patients, caregivers, family members have unique perspectives on care, including diagnostic safety. There's definitely a tension between what's in the medical record and what the patients are experiencing in their diagnostic journey. And there's an opportunity for us to improve and learn from those experiences to improve diagnostic safety. Our current methods are cumbersome, they're challenging, and time sensitive. They take a long time to do. So we need better tools to improve our diagnostic safety surveillance from the patient's perspective. What's going on in our work now is we're developing some of those tools that we can apply from diverse patient populations. We can develop them and co-design them with patients from those diverse populations and marginalized communities to help enhance care and trust with the system, and make it easier for patients to report and use that data, make it easier to use it within our healthcare system. So I want to thank the Agency for Healthcare Research and Quality for funding all of this work. They're a lead partner in our work, and we're very excited to launch our Diagnostic Center of Excellence, our Patient Partner Diagnostic Center of Excellence. So we'll be sort of building on this work for the next 4 years. And thank you.
Thank you very much, Dr. Kelly, for this presentation and this research, which I learned from a lot, because we usually assume things, but when you research and have results, it just supports what you think or what is really going on. So thank you very much. Now, moving on to our next presentation, society's role in improving diagnostic safety, presented by Dr. Khalid Khadr. Dr. Khalid Khadr is a consultant for quality and healthcare services, PhD in health services management, quality of healthcare services, supervisor of business development department, Ministry of Health, and board chairman of the Quality and Healthcare Association, and also the board member of the Saudi Society for Health Administration. Welcome, Dr. Khalid.
Thank you very much. I would like first to thank the Saudi Patient Safety Center for organizing this valuable conference talking about important topic, which is diagnostic safety based on patient safety. And also thanks to all the teamwork who's working in this conference. Also, I am honored to be a part and a speaker on this conference. My topic, let me share it here. Okay. I'm not sure where is the sharing. Okay, it's here. Please let me know if it's appear. Is it okay now?
Still, it's only your image.
Okay.
Try one more time.
What is it about now?
Yes, now, perfect. Thank you.
Great. Thank you very much. Okay, so my topic is about society's role in improving diagnostic safety. We're talking here or today about what's quality and patient safety, and why is quality and safety important in healthcare? What is diagnostic quality and society's vision toward diagnostic safety?
Dr.
Objective
Khalid,
of
I'm sorry. Is it possible to hide the bar below? Just you can click on skip.
This one?
Thank you. Yes.
Great. Thank you very much to inform me. Okay, objective of the quality in healthcare associations, and how can we diagnose be improved, and what our vision, the key points for improving diagnosis, the health services management competency framework, and using patient experience survey to assess diagnostic safety as a tool, and words about diagnosis, conclusions, and the end recommendations. What is quality and patient safety? Actually, the simple word about the quality, which is defined by the HRQ, is doing the right things at the right time for the right person and having the best possible result, which is, as we know, providing a good quality of services and avoid harm and hazard for patients. For the patient safety is the prevention of errors and adverse effects to patients associated with health care. Why is quality and safety important in healthcare? The first is its aim to prevent and reduce risks, error, and harm that occur to patient during provision of healthcare. Also, it's a cornerstone of the discipline is continuous improvement based on learning from error and adverse events. The third is patient safety is fundamental to delivering quality essential health services. Okay, here what is the diagnostic quality? Diagnostic quality refers to how well the staff and practitioners perform tasks related to diagnosis of patients, including accuracy, completeness, timeliness, and precisely of diagnosis. If we see here, we can find that most of the words or topics talk about the some of how to the quality dimensions, which is related directly or indirectly to patient safety and affect patient and either harm or in a good quality of services. Society's vision toward diagnostic safety. This is our society, and most of the societies is working on these six pillars, which is one of them is training of healthcare professionals via providing short or long-term courses toward patient safety, patient diagnostic safety, about communication skills, about how they can educate patient, how they can engage patient in decision making and treatment plan. All of these training courses can societies provided, and it's very important to avoid and to patient harm or hazard and improve quality of health services. Patient educations. Patient education is the practice of information patient about their wellness, treatment plans, potential outcome, and other information critical to the patient experience. The resources could be one-to-one, for example, teaching, demonstrating, and analogs or word picture to explain concepts related to patient and his treatment. The third is supporting the health institutions. This could be during establishing of standards, enhancing the aspects of healthcare services inside these hospitals, providing survey to express or to find out patient experience, patient satisfaction about the healthcare they provided, if there is any. And I think Kelly and others talking about the assessment and survey patient experience. Also, we can work also in accreditations of the hospitals. And as you know, there is for Sabahi, there is a 20 items about ESR, essential safety requirements, talking about patient safety, and most of them is talking about diagnosis regarding medical medication, regarding anesthesia, and different aspects of quality healthcare. Patient empowerment. Patient empowerment is talking about increased patient satisfaction with care, improved patient adherence to self-management of the treatment, and better clinical outcome. According to the WHO, patient empowerment can be defined as a process through which people gain greater control over decision and action affecting their health. So it's very important also to engage the patient and empowerment for their treatment plan and medication. This will has a good result for also patient cultural safety. It's very important also for the organization and the families and the patient to have a good knowledge about the safety, and we can work as societies in improving the culture of patient safety. Development specific programs, and we're talking here about different program related to diagnosis safety, patient safety. And this program could be short, for example, last for 2-3 weeks to till 1 year, depend on the institution and the desire of the healthcare professional, if they need to work and improve their skills and knowledge about patient diagnosis safety. Also, we can contribute to the development of standards to ensure diagnostic safety. Here, by contributing with the organization, we can build like standards based on the what used in the world regarding the diagnostic safety, and they can motivate to work in the hospitals in Saudi Arabia. Objective of the Quality in Healthcare Association, we have 4 objectives. One of them is spread of the culture of healthcare quality in health institution and facilities. The second is contribute to the development of the quality of healthcare and services provided to patient and customers, including patient safety and patient experience. Raising the level of performance of health workers in the field of healthcare quality via conducting short and long term training courses for the healthcare professionals and the people who's working in the hospital and has direct or indirect contact with the patient. Also, participation with the relevant organization in developing the quality of healthcare and sustainable health development to face the challenges. Okay, here we can talk about how can diagnosis be improved. Actually, we have 3 points or 3 way or method for improvement. One of them is enhanced healthcare professional education and training in the diagnostic process. So getting the right diagnosis depends on all healthcare professionals involved in the diagnostic process receiving appropriate education and training. The learning sciences, which study how people learn, can be used to improve the education and training. For example, feedback or information about the accuracy of healthcare professional diagnosis or physician or doctors. It's very important and essential for improving diagnostic performance. The learning also environment can affect the diagnostic skills. So better alignment of training environment with the clinical practice promote development of diagnostic skills. Opportunities to improve this education and training in the diagnostic process include different methods or different ways. A greater emphasis on teamwork and communication with patients, their families, and other healthcare professionals. Appropriate use of diagnostic testing and the application of test result to subsequent decision making, and the use of health IT, which is very important for this improvement. The second is ensure that health information technologies support patients and healthcare professionals in the diagnostic process. Health IT has the potential to improve the diagnosis and reduce diagnostic error, facilitating timely and easy access to information, communication among healthcare professionals, patients, and their families, clinical reasoning, and feedback and follow-up in the diagnostic process. However, many experts are concerned that health IT currently is not effectively facilitating the diagnostic process and may even be contributing to diagnostic error. Challenges include problems with usability, poor integration into clinical workflow, difficulty sharing and patient health information, and limited ability to support clinical reasoning and identification of diagnostic error in the clinical practice. So, better alignment of health IT with the diagnostic process is warranted. The third is develop approaches to identify, learn from, and reduce error and near miss in clinical practice. So, due to the difficulty in identifying diagnostic error and competing demand from existing quality and safety improvement, very few health organizations have processes in place to identify diagnostic error and near miss. So identifying these experience, learning from them, and implementing changes will improve diagnosis and reduce diagnostic error. Healthcare organization can also ensure that systematic feedback on diagnostic performance reaches individuals, care team, and organizational leadership. The other things we can talk about is how we can improve diagnosis. So there is a key points for improving diagnosis as views of the society and especially the quality in healthcare society. So we have the most important three things to improve diagnosis. One of them is involving patient involving patient in decision making. So involving patient, we can say it is central to improving diagnosis. As we know, diagnostic errors are often underreported or poorly reported. So underlying causes may be difficult to ascertain or hidden by the unrecorded details of individual condition and patient-clinician interaction. So patients' report of their experience of diagnosis error can provide information that traditional measurement mechanism often fail to capture. Given the absence of diagnostic specific experience in most surveys and patient-reported outcome, the only current way to capture patient experience of diagnostic error is via patient complaint. However, complaints are often viewed as satisfaction matter rather than safety single. In addition to system factor and individual clinical reasoning, diagnostic decision making can often be affected by complex factors involving patient-physician interaction, many of which remain elusive. So patient experience may highlight how soft factors, including patient and clinician judgment and specific behavior and interpersonal factor, can affect diagnostic safety. The other one or the other factors that could be improved, can improve the diagnosis, is ongoing and lifelong communication training skills. This help actually the healthcare professional to elicit and respond to patient input in the context of diagnosis that could lead to reduction of diagnostic error. For instance, physician and patient often approach their interaction with different expectation and perception. These interactions determine the type of language used and information communicated. A mismatched expectation can lead to miscommunication that lower patient satisfaction and understanding, which in turn poses risk to patient safety. Lifelong learning strategies could include training on managing patient expectation, including factors that build or damage rapport through this course, and the importance of shared expectation for patient safety. So current medical education program for physician could include this type of training. The third is to identify the key competencies that should be considered for inclusion in the health profession education program to improve the quality and safety of diagnosis in clinical practice. And here, the work of the Saudi Society for Quality in Healthcare on these competencies, and we will share in the next slide here the health services management competencies framework. This framework, including 5 dimensions, these dimensions is leadership, health and healthcare environment, business skills, professional and social responsibilities. These actually competencies has been modified from the competencies used in Australian healthcare system, and we try to work on this as a model for the Saudi competencies, and we have already prepared based on the information that received from pilot studies, from training courses, from different workshops that we did in order to do some modification to make these competencies suitable for Saudi society and for Saudi healthcare system. These domains include leadership, which is talk about the ability to inspire and organizational excellence, create a shared vision, and successfully manage change to attain an organization's strategic goal and successful performance. The competency areas, including leadership skills, lead the way, engaging culture, cares for people, leading change, collaborates across the system, drives for value, driving innovation, puts client first. These leadership intersect with other 4 domains, which is health and healthcare environment.
I just want to remind you we have 5 minutes left.
Okay, thank you very much. Understanding of the healthcare system, which is including 4 competences, domain, health system, health workforce, person, and population. Domain 3, business skills, and here maybe the most important thing relate to our patient safety, understanding and applies business and corporate principle management and system thinking to the healthcare services. Competences area include governance, financial, human resource, strategy, and risk management, and quality and patient safety. We consider and focus on this subdomain. Also, the 4th one is communication and relationship, and we will focus on communication skills, engagement, and marketing. The 5th domain is professional and social responsibilities, which include professionalism, advancing health management, self-awareness, ethical conduct, and social responsibility. Here we talk about the quality and patient safety in the 3rd dimensions, and here some of the aspects or that could help to improve healthcare professionals' competences. One of them is develop and implement, evaluate quality improvement and patient safety approaches and program within the organization, develop and track indicators to measure quality outcome, satisfaction, and patient safety, apply tools to measure consumer experience and satisfaction for continuous improvement, ensure individual and systematic feedback to learn from potential and actual error so required action can be taken to improve the system. Also about the communication skills, We can play a role in exercise cultural sensitivity in internal and external communication, demonstrate strong listening and communication skills, verbally and writing and visually communicate data, demonstrate effective public relations skills through appropriate communications, and apply marketing principle and tools to develop marketing strategies. And this could be done by marketing on patient diagnostic safety, on patient cultural safety, different aspects related to patient diagnostic safety. The other tool is using a patient experience survey to assess diagnostic safety. We can also play a role here in patient. As we know, patients have unique and powerful insight on diagnostic safety. Patient experience survey are unlikely but rich source of patient perceived diagnostic safety issues, particularly identifying issue and information gathering, history and physical examination, for example, and treatment. Therefore, healthcare system should promote the utilization of patient experience survey to estimate the impact of diagnostic error and to design system-based solution for improving diagnostic safety. Here's some word about diagnosis. The foundation of medical practice. It's notable or remarkable that the training of most health professionals, there is no specific course in diagnosis. Diagnosis education mirrors diagnostic practice. Conclusion, there is an important growth in understanding the mechanisms that contribute to the harm associated with diagnostic error. Diagnostic process is complex, play out over time and space, and uncertainty in the norm. Various cognitive and system-related contribution to diagnostic error have now been identified. Incorporating the new knowledge of diagnostic safety into health profession education and training has the potential to substantially improve the diagnostic process and reduce the harm associated with diagnostic error. Recommendation, adding more content, skills, professionalism, and safety knowledge to maintenance of certificate and continuing medical education processes would ensure that healthcare professionals routinely refresh their knowledge and skills in these areas. Patient can be valuable in gaining a comprehensive understanding of diagnostic error and informing strategies for mitigation. Third, health system should proactively develop and implement formal programs to collect patients' experiences, including interpersonal and clinician behavior issues. This program engage patient, families, and caregiver in the diagnostic process and help prevent diagnostic harm. The fourth and the last, the related societies can be engaged to identify high priority areas to improve diagnosis. Early effort could focus on identifying the most diagnostic error. Don't miss health conditions that may result in patient harm or diagnostic errors that are relatively easy to address. Thank you very much for listening. And this is my contact Twitter. If anyone need to contact with me or speak with me about any relevant topics, this is my pleasure. Thank you very much all, and mic to you again. Thank you very much.
Thank you, Dr. Khadar. Thank you very much for this comprehensive presentation talking about the role of societies and other aspects of diagnostic safety. Thank you very much, Doctor. Now moving on to our last with Dr. Abdelilah Al-Hawsawi, talking about patient and family advisory council's role in improving diagnosis. Dr. Abdelilah Al-Hawsawi is the CEO of Noor DX, the kingdom's first genomic and bioinformatics company. Noor DX mission is to use individual genomic information to screen, diagnose, and empower clinicians and patients to make effective and personalized healthcare decisions in treatment and prognosis. Dr. Abdelilah is the former Director General at the Saudi Patient Safety Center and MOH advisor on patient safety. He holds dual certificates from American and Canadian. Dr. Hawsawi is now currently part of the WHO Global Patient Safety Action Plan Task Force. Welcome, Dr. Abdelilah.
Can you hear me?
Yes, we can hear you.
So thank you very much again. I just want to make a correction. Actually, I have no relationship with the organization that you mentioned earlier. I'm the CEO of Novo Genomics, which is based here in Riyadh. So just to clarify, I have no relationship with the organization that you mentioned. But otherwise, all the other information that you mentioned is accurate. Do you guys see my slides?
No, not yet.
I see it. I see here that it says stop sharing.
Maybe you can stop sharing. You are sharing your screen, but your whole screen. If you can present only the PowerPoint.
Yeah, that's the thing. Let me try again because.
Okay, take your time, doctor. So if you need us to share your slides from our side and then you ask us to move to the next slide, you can do that too.
No, it should be okay. Do you see that? It's using microphone. What? So
Yes,
it looks like
yes.
it's sharing here because it has stopped sharing. Do you guys still not see it?
We are seeing your presentation. If you can just click on the presentation mode, full screen mode, yes.
Okay. So I'm going to talk about the Patient and Family Advisory Council and their role in improving diagnosis.
I'm sorry, Dr. Abdullah, can you click it again because still we can see the whole PowerPoint application?
You don't see it yet?
We see it, but can you click the full presentation mode again?
It is clicked. Let me click it again. Okay.
Okay, thank you. You can start, Dr. Abdullah. Okay.
Okay. So just few concepts here, and I hope giving the work of patient safety within the kingdom and the efforts put forward by the Saudi Patient Safety Center to empower patients and families. The concept of a Patient and Family Advisory Council is clear. So that's one of the take-home messages that I want to leave you with, which is if you don't have a Patient and Family Advisory Council in your healthcare organization, be it a hospital, be it a polyclinic or an ambulatory care center or a primary care center, if you don't have a Patient and Family Advisory Council, please start that. It has a lot of positives and almost no negatives. As the name indicates, it's a council or a committee that is made up of patients, family members, and healthcare professionals. I think it would be good to look at it even through the current design that the Saudi healthcare system is going to, which is the health clusters. It would be nice to have the members, not necessarily just patients, but it would also, because the patient is a patient at some point and not necessarily a patient all the time. You might have someone with chronic diseases. So I would say community representatives, if we're talking about a population-based healthcare, having people with chronic diseases, having people with history of being hospitalized. So it's important to have those people that are passionate and committed about contributing to the healthcare system, leveraging their experience, either ongoing experience if they are people that are chronic people with chronic health diseases, all people that had experiences in the past that would want to see done in a different way. So again, the Patient and Family Advisory Council is a committee that has patient representatives. You can say representative from the community, and that sums up the patients and the family members, as well as the healthcare providers. And without getting into all the details of the slides, I would say it promotes the concept of co-production. So co-production is the fact that if we want to provide a high quality and safe care for the community, for the patients, for the individuals, we have to co-produce it. In other words, we as healthcare providers side, as well as the patients and family side, we have to co-produce it together. And that's the concept of, if you want to put one objective of the Patient and Family Advisory Council, it's the concept of co-production. And co-production has different components to it. There's the co-design of designing how the services are. So if you are a women and children hospital with so seeing most of those patients in your practice, then how the design of the services from the beginning of the kind of contact that the individuals have with the healthcare provider, and this is where the alignment of patient experience, quality, and patient safety all come together, because they have to be together, because the patient experience is very much one side of the coin of the patient safety and patient experience. So again, the take-home message here is to have a Patient and Family Advisory Council if you don't have one. If you have one and it's not active and it's not impactful, please make sure that you activate it. I think the community is very much interested in having those and having them being active and focusing on the continuous improvement of the care experience. So why should we have it? Evidence shows that having a Patient and Family Advisory Council, those organizations and hospitals achieve better quality and safety scores than those without, which is a no-brainer, giving that it is, again, a vehicle for implementing co-production. So there's a concept of patient and families as advisors, and not necessarily think about them as advisors. I think we can think about a patient-centered care, or at a bigger level of a citizen centered care, because this would highlight the population-based healthcare, and I think this is where not just thinking of them as advisors, but thinking of them as a center of everything that we do, and as an important co-participant, not only in their care or the care of their families, but in the care in general. So what does that entail? To have the patient and families participate in regular Patient and Family Advisory Council meetings, to have them, push the agenda of what those meetings would look like, to have them participate in some of the initiatives across the organization. I talked about the co-design of the co-production. There's also the co-delivery of care. There's the co-assessment of care. So even doing an internal audit through an organization, you can use the Patient and Family Advisory Council to have a look at the healthcare provision from the community side. I think there's a lot of valuable lessons that could be taken from that. Dare I say that they would participate in staff training initiatives just to bring the patient aspect to those meetings. Sharing stories, stories are very powerful. So we can talk about theory all time, but then you can share a powerful story that would summarize a lot of messages and things that we want to push forward. There are certain factors that support the successful involvement of patients and family advisory councils in patient safety. And I hope by now I convinced you that, we have to have, it's the year 2022, we're going into 2023. By this time, I think if you are an organization that does not have a patient and family advisory council, I think you're not an up-to-date organization. I think you're an organization that is living in the past. So you can mention, you can take this and quote me on saying that. I think at this stage, every organization should have at least that structure, and hopefully which should have a patient and family advisory council that is active, not just an optics organization. And you can see here leaders, because it starts with leadership. I think if the leaders do not believe in that, and then this would not move forward, and not just by talking the talk, but then by walking the walk as well. So their actions show their commitment to this belief. Patient and Family Advisory Council members are asked to provide feedback, as I mentioned, and because they have been through the system, because they have family members or friends that went through the system, they could identify some patient safety areas, priorities that are overlooked by the providers. The walkabouts, and as I mentioned, auditing, I think that would also be very helpful. So to kind of move forward by making the case that Patient and Family Advisory Council as a structure and as a process is important. So what's the outcome that we're looking for? The outcome that we're looking for is improving safety. And in this particular case, we're talking about diagnostic safety. The Society to Improve Diagnosis in Medicine has an amazing website. I think it has different resources, and I believe there's a lot that we could learn from them. And these two guides put forward are also some of the evidence that show that the practice of Patient and Family Advisory Council will improve the diagnosis in the diagnostic safety in general. So this is to repeat some of the points of why Patient and Family Advisory Councils would improve safety. As providers, we cannot be everywhere at the whole time. Not to mention that patients and families are a great resource and a great source of information about the healthcare provision process, either in the inpatient setting or in the outpatient setting. And I think we could really get a lot of benefit and feedback if we empower them to be part of the feedback of the information that we would get. As I mentioned, the observations of the council members provide valuable information about the areas of risk. And you can think of the Patient and Family Advisory Council as a change agent. I'm sure some my colleagues, physicians and clinicians would think that patients should just be patients and should just stay on the receiving end of the care. I think this is yesterday's way of healthcare provision. If we really want to improve safety, if we're serious about it, if we want to improve the diagnostic safety, then we need to have active and involved patient and family advisory councils, which would activate and empower the patients and families and the wider community that receives care from those healthcare providers. And again, it goes back to the point of why this is a very powerful change agent tool. So here are the 5 steps that you can take to leverage your patient and family advisory council's influence to drive change. One is to educate your council about diagnostic quality and safety, connect with top organizational leaders, provide opportunities for your community to learn about the diagnostic process, advocate for full engagement in patients and families in preventing diagnostic errors, either in the inpatient setting, in the outpatient setting. Emergency department is also an area that, because of the complexity and the large volume, is an area that could see a lot of diagnostic challenges and errors. So how can you deal with that? And one thing also to mention, with the explosion of the telehealth and virtual care, I think we have to be careful about making sure that we don't end up with diagnostic safety challenges while we're kind of rolling out these advanced platforms to provide care, but it's different from the face-to-face care. So any technology it's a double-edged sword. I think we need to focus on the positive of it, but also we have to be mindful of the potential harm. And finally, advocate for systems and processes to improve diagnostic quality and safety. So again, خير الكلام ما قل ودل. Just want to kind of zero down on what I mentioned earlier. So, we talked about the Patients and Family Advisory Council. You can think about those as a committee that has representation from the community. So patients, their families, or people from the community. So patient representatives, if you will, and on the other side, the healthcare providers. And these have to be present. Again, I hope that if you don't take any one thing from me, is to, if you don't have a patient and family advisory council, is to establish one right away. And if you have one that is not active, make sure that it's activated, because it's a very powerful tool if the leadership is there, and if the intent and the commitment is to improve the quality and safety and the patient experience. I think a lot can be done from such council. It goes without saying, I highlighted the co-production, which is the co-design of care, the co-delivery, the co-assessment. These are all areas that could be discussed on the Patient and Family Advisory Council. You could figure out, based on the scope of service of the hospital or the clinic or the primary care center, what areas of higher safety concerns are, and how we can kind of zero down on those, including trying to reduce diagnostic errors. I would say that high volume centers with busy emergency departments are areas where from a risk management potentially have a higher risk of diagnostic errors. The virtual healthcare, the telehealth, these are also another platforms that have a lot of advantages, but I think the potential for diagnostic errors to go up if we're not careful, is there. So with that, I thank you for your time and looking forward.
Thank you very much, Dr. Abdulillah. Thank you for this presentation and this important topic about patient and family advisory boards or councils that are being established in each cluster and also on directory level. Thank you very much. I would like to invite all speakers to the main stage, as we are going to receive questions from our audience. We already have a couple of questions from our audience. I will start with some of questions about the patient and family advisory presentation. Here are someone asking, how can sharing stories in the patient and family boards help improving patient safety? And how can I differentiate between sharing a story and complaining about my healthcare plan or my healthcare services provided to me? Dr. Abdulillah.
Sure. Sorry for coming in late. I see a lot of familiar faces and friends. So
welcome, Ms. Helen and Dr. Kelly, Mr. Hussein and Dr. Ria Khadr.
My greetings to all of you. Stories, actually, we think in stories. We relate with stories. Stories can send a lot of messages, because we can talk from a theoretical perspective, but if I come in and I say I went through this, my son, my wife, my father went through this experience, and going through the story, highlighting where the healthcare providers were tone deaf, they did not listen. There's a study that talked about, I think, the time between the patients talking about their complaint and physicians, us interrupting them is like it was 15 seconds, I don't know, maybe 20 seconds. So we're very, very quick to kind of actually cut them off, and that could be a risk of potentially having diagnostic error, because we just did not give. No one would like to kind of wake up in the morning and say, okay, I want to go to the hospital. You go, this is a place that you go to because you have to go to. And so I think it's spending time just to listen to why the patient, is there, is there any information that is missing? When you articulate that in a story, I think it can be very powerful.
Yes, I agree. I totally agree. But maybe a culture needs our culture needs improvement in being transparent and honest, and also bold in telling their stories. We have also a question here for Dr. Kelly, asking about you said that we need to improve or come up with better tools to improve communication among patients. So what better tools, or what you have in mind, you or your team that worked on the research in coming up with better tools, or how to come up with better tools among health clinicians?
It's a great question, and thank you for that. Actually, Helen and Hussein presented on a few of the tools that our team has co-designed with patients based on this feedback that we've learned. One is the Be Prepared to Be Engaged tool, which is an agenda setting checklist that patients can use to prepare for their clinical encounter. That's been used primarily in primary care, but also in some specialty outpatient care settings. So that's one tool that we have already developed, and it's available for free on the website for the Agency for Healthcare Research and Quality. The next tool that we co-designed specifically for diagnostic safety was the Be the Expert on You note sheet, and that really has been demonstrated to be very effective at connecting the dots with communication in the encounter. It's been used in hospital settings, ambulatory care, home care, and it's a very simple tool, but the goal with that one, it's a paired tool with a listening training. So Dr. Kader talked about listening and how we could, that training of healthcare professionals is key and critical. And so our team recognized the links between the two, preparing the patient to talk and preparing the clinicians to listen. And so that paired tool is available on the AHRQ website as well, to implement and to potentially train future clinicians about the power of listening and overcoming that interruption, that 7 to 18 seconds of time that we often let a patient talk is very limited. And the expectations around that conversation are very different. So when you interrupt a patient, they think you've got the answer already and they don't need to continue telling their story. And oftentimes it's just because the clinician's curious about their pathway, their cognitive model, their diagnostic hypothesis. They want to test that hypothesis, but really the pearls might be later in the patient's story that would change the diagnosis. So those are tools that are active out there. We're also co-designing algorithms for health systems to better utilize their data that they collect already from patients. Oftentimes we say, let's do another survey, let's add questions. And really, our patients have been telling us this for years, that they're already giving us the information that we need. We just don't have a good way to use it. And so our team is actively working on those tools as we speak.
Okay, that's great. Thank you very much, Dr. Kelly. I don't know if Ms. Helen and Mr. Hussein has anything to add. I think your mic is muted, Ms. Helen. Yes.
No, I think those are good tools, and there are others available. Also, the Society to Improve Diagnosis in Medicine has a very detailed tool. It's much different from the ones that Kelly created at HRQ, but it's it's sort of a long-term document if you wanted to keep it and record your the progress of your diagnosis and things you wanted to ask the doctor. And questions that you wanted to remember. It's on the Society website, which is improveddiagnosis.org, the patient toolkit.
Yeah, thank you very much. We have a question here that can be directed to you, Mr. Hussein or Ms. Helen. Culture awareness and diversity could be a great challenge, since you talked about patient safety or patient diagnosis issues. What are the quick wins that could work better to change the community culture or improve or work with the culture diversity?
Do you want to take that, Hussein?
Yeah, sure. Can you hear me?
Yes.
Yeah, I think we should not try to change the community culture. I think that's not the way forward. I think what we need to do is to understand the cultural norms and how the culture works, and I think that's the way forward. And I think the best way to begin with, if you have any patient organizations, I think that is the first step to take. So you take them on board, and and then I think you can plan with them, you can work around them, because they represent a number of patients, a group of patients, all patients that are there. You can talk to them, you can plan things out, how can community be made aware of the important issues that we want to highlight. How can community be engaged? If there are any do's, if there are any don'ts. I think that's very important for healthcare providers to understand, because in certain countries where you have the healthcare providers moving from other countries, or maybe even within the same country, there's different cultures prevalent. So I think it's important for the healthcare providers to be respectful of the community, the culture that is there, the prevalent norms, and I think involving patients through patient organization, or through leading patient advocates, if there are any, I think would be the first step. But I think it's important to understand what's happening with the patients, communicating with them, understanding their issues, empowering them, giving them, some sort of trainings, health literacy, and then, making them involved in their own healthcare and working towards patient-centered healthcare.
Thank you. Thank you, Mr. Hussein. Another question about societies. I would like to direct Khalid. Societies are varied. So there are direct care societies, and there are societies that are collaborating with healthcare institutions and healthcare providers. So here's the question. What are the societies working on to improve the patient health literacy? Since patient health literacy is very huge and important role in improving the engagement and the empowerment of the patient. So is there any ideas or projects that are being established toward improving patient health literacy with societies or among other organizations?
Thank you for this question. Actually, different societies has different aspect looking at the patients and how they can improve patient diagnostic safety. In general, most of the societies working in two arms or two areas. First of all, from the view of the healthcare professionals, and the other view is the patient and their families. For the healthcare professionals, we know that they concentrate mostly in doing training courses, development programs, CPDs regarding patient safety and how they can improve the knowledge and the skill of the healthcare professional regarding patient diagnostic safety. From the side of patients, there's also different programs based on the type of the societies and the objective of the societies. For example, our society, talking about the quality of healthcare services, and one of the most important things is patient safety. So one of the most of programs that we're trying now to focus in is doing like a short course program concentrate on how to provide and how to educate the patients on understanding their health status and how they can communicate well with the healthcare professionals. This is via contributing with the health institution themselves, and we try to do like criteria or standards, put it in the model or framework that help both the institutions, healthcare professionals, together with the patient and families in order to have a good communications regarding patient safety and patient well-being. Thank you very much.
Thank you. This moves me to another question to Dr. Abdulillah, talking about how can we include a patient in the healthcare professional training? You suggested that it's a very important thing to include also patients when talking to healthcare providers or when providing trainers to healthcare providers. So how can we include it to patient, and how can the community adapt to that or accept this kind of idea?
So, I participated in events of cancer survivors, for example, as a clinician, and kind of just listening to them speak about their experience. It gives you an idea about what you're doing right, but also what you're doing wrong, and B, it highlights that angle of what the patient side that is always overlooked. I think I shouldn't say always, but often overlooked. So this is where, to go back to the practicality, I think this can be done at the level of some trainings promoted and suggested by the Patient and Family Advisory Council in areas that are seen to be safety concerns. You know, it could be departments related, it could be diagnosis related, it could be different things. So think from a risk management perspective, the most practical way of doing it is, you know, figure out what your scope of services, and figure out what are the historically what are the high risk areas from a safety perspective, and then you can devise some training accordingly, and have, you know, I don't think it should be just provided by patients or patient representative. I think having the, you know, patient reps and the community representatives give that side and tell us providers how we come across in certain areas is helpful, and to show areas for improvement moving forward.
Thank you very much, Doctor. We would like to have one more question, and the last question, but not least, for Dr. Kelly, asking about, you mentioned that there was a unique observation of patient being able to identify diagnosis, mislabs, or misdiagnosis. So in your survey or in your research, did you ask the patient what they did when they noticed that? Like, they mentioned in a text that they noticed misdiagnosis, but have they done anything, or did they recommend something?
Most of the time, what patients do when they recognize a breakdown in the diagnostic process is that they seek care somewhere else. Because of that breakdown in trust between the patient and the healthcare setting, oftentimes they'll go to a different setting. They'll go to a different doctor. They'll go to a different organization or healthcare system entirely to seek care. And what happens in those instances is that all of the information is lost. Learning opportunity for the health system that created that diagnostic uncertainty, or maybe failed to convey diagnostic uncertainty. Oftentimes, patients believe that when they go to their physician, they're getting the answer. When a physician, on the physician's perspective, oftentimes they're just asking another question. They're trying to rule out a diagnosis versus rule in. And so we think that that bidirectional communication is really critical, and acknowledging uncertainty from the clinician's perspective would go a long way to bringing the expectations of the patient closer to the expectations of the clinician. And so our goal is to create an opportunity for that open and transparent communication.
Thank you. Thank you very much, everyone. And I would like to thank each speaker talking about patient empowerment and patient engagement, and how important it is to improve diagnostic safety or patient safety. And I would like to extend our thanks as SPSC and as Lamia. And it was an honor knowing all of you and learning and listening to you today. Thank you very much.
Thank you very much.
Thank you.
Thank you, everyone.
Thank you very much. Appreciate it.
Okay, we have come to the end. I would like to thank every one of you for being with us. I would like to thank our speakers, our partners, and you, the attendees, for sticking around to the end. Remember that patient safety is a team sport. It does not start with management. It does not start with the leaders. It starts with you, everyone's responsibility. So speak up for patient safety. Talk to your leaders. Reach out to resources that we've mentioned during these 2 days. Reach out to us in the Saudi Patient Safety Center. We're here to support you and help you as much as we can. Again, thank you so much for being with us.